galactorrhea and hyperprolactinemia, a brief overview of galactorrhea, the physiology of lactation, causes of hyperprolactinemia, and the management of hyperprolactinemia. Galactorrhea is defined as the release of a milky discharge from the breast and related to the postpartum period, at least greater than 6 months after childbirth in a reproductive woman. It can also occur in males. It is often bilateral. It could be spontaneous or expressible, although expressible or spontaneous galactorrhea tends to be less frequent in men, primarily because the breast tissue in men has not been exposed to the effects of progesterone and estrogen, making it less likely to proliferate under stimulation from prolactin. So what's the normal physiology of lactation? So prolactin is an anterior pituitary hormone and is the main driver for milk production. As mentioned earlier, estrogen and progesterone are required for duct and lobular development of the breast, and this explains why men tend to have it less frequent than women. So there's a higher incidence of galactorrhea in women compared to men, primarily for this reason. Also, during pregnancy, prolactin peaks at delivery, and it's actually greater than 10 times the upper limit. And the milk lets down response or suckling increases prolactin levels. It's also important to realize that dopamine is also known as prolactin inhibiting factor released from the hypothalamus normally suppresses prolactin release. So let's look at this section of this chart. You can see right here is prolactin, and let's look at the inhibiting factors here will be mainly dopamine, and the promoting factors for prolactin release would be thyrotropin releasing hormone, oxytocin, VIP, and neurotensin. And I think for our purposes, let's keep a close eye on TRH. So this will be relevant later as we discuss the causes of hyperprolactinemia. So prolactin goes to the breast tissue and then increases milk let down. But this is dependent on the effects of estrogen, progesterone, and human placental lactogen, especially in pregnant women, because these three hormones are required for duct proliferation and differentiation. So let's turn our attention to this other side of the hypothalamic pituitary gonadal axis, in that GnRH, or gonadotropin releasing hormone, responsible for the release of FSH and LH, is also under the influence of prolactin. So if there are high levels of prolactin, there is a reduction in the levels of GnRH, and this consequently reduces the levels of FSH and LH. And as a consequence, there will be low levels of estrogen and testosterone. And this has implications for fertility, also has implications for bone function, optimal bone function, and sexual function in terms of libido, etc. So what are the causes of hyperprolactinemia? And it's best to think of it in terms of the underlying pathophysiology. So if they have pituitary stalk lesions, for example, you would have impingement of the pituitary stalk by maybe an extrinsic mass, and this disrupts dopamine pathway, resulting in increased prolactin levels. Prolactinomas directly release the excess prolactin, leading to all the effects of hyperprolactinemia. And then some medications, especially atypical and typical antipsychotics, These are dopaminergic antagonists. They block the inhibitory effect of dopamine, and this reflexively increases prolactin levels as well. And then, as I mentioned earlier, in patients with primary hypothyroidism, there's a reduction in free T4, which is sensed by the hypothalamus and the pituitary, and consequently resulting in an increase in TRH. And TRH, as I said, is a prolactin secretagogue. So this stimulates anterior pituitary lactotrophs, which consequently release prolactin. And then chronic renal failure, because of the reduced clearance of prolactin, this results in hyperprolactinemia. So these are various causes of hyperprolactinemia, and we shouldn't forget, of course, chest wall stimulation or nipple stimulation being a common cause, or breast hypersensitivity, especially with the milk letdown response, as we mentioned earlier, can also result in hyperprolactinemia. So the management principles requires a few steps. So treat the underlying cause. So if it's a tumor, either medical therapy if it's possible, or surgical, transsphenoidal surgery, or medications. And if it is due to hypothyroidism, for example, then treatment with levothyroxine would be enough to lead to a spontaneous resolution of hyperprolactinemia and consequently galactorrhea in these patients. So there is also medication-induced causes of hyperprolactinemia, as we mentioned earlier, for the atypical and typical antipsychotics. And because these drugs are actually dopaminergic antagonists, withdrawal of these medications also leads to resolution of hyperprolactinemia. And another broad category would be non-hyperprolactinemic galactorrhea, and this is often benign, and all the patients require some form of reassurance. So additional points would be that pituitary tumors and the treatment with dopaminergic agonists, it's important to monitor size and function, and if these tumors are unresponsive, surgery and radiation are possible options, especially if there's mass effect like impingement on the optic chiasm or extension into the cavernous sinus with cranial nerve deficits. And another known complication here would be CSF rhinorrhea, and this can occur in large pituitary tumors, and we can shift our attention to this illustration here. So you can see that a pituitary adenoma occupying this region of the sella, especially in macroadenomas. Okay, so these are the tumors greater than 1 centimeter. It kind of, when these patients receive dopaminergic agonists, these tumors can literally shrink away. Okay, and as it shrinks away, there is a bit of a space, a potential space in the suprasellar region that allows CSF to leak into the pituitary cella, and this can lead to either a partial empty cella or a complete empty cella. And consequently, some of these patients, especially after surgery, they can actually develop CSF rhinorrhea as a consequence of treatment. So galactorrhea is frequently linked to hyperprolactinemia, and hypothyroidism is a known cause, primary hypothyroidism to be specific, because this complication does not occur in secondary hypothyroidism. So it has to be primary hypothyroidism, low free T4 and high TSH due to high TRH, and the TRH would reflexively increase prolactin levels, resulting in hyperprolactinemia. So prolactinomas, most common, these are the most common hormone-secreting pituitary tumors. So of the functional pituitary tumors, about 45 to 50% of them would be prolactin-secreting tumors, or prolactinomas. And majority would be microadenomas, obviously, which means less than 1 centimeter, or microadenomas. Also, they are usually benign, okay, and they occur sporadically in majority of patients, although on rare occasions it could be part of the multiple endocrine neoplasia syndrome. About 10% of these tumors also co-secrete growth hormone, so it is important to evaluate IGF-1 in any patient presenting with hyperprolactinoma. Remember that there is a single embryonic origin for lactotrophs and somatotrophs. So the somatomamotroph, okay, somatomamotroph cell during embryonic development. So it is important to realize this relationship and the fact that sometimes prolactin tumors can co-secrete growth hormone as well. The pathophysiology of prolactinomas, mainly monoclonal lactotroph adenomas, which result in these excess prolactin states. And as I said earlier, they could be either micro or macro prolactinomas. The microadenomas are usually more common. They present earlier in women. They rarely have mass effect, and prolactin levels are typically 100 to 200 nanogram per ml. It presents much earlier in women because women usually would initially present with amenorrhea and oligomenorrhea, and for that reason they tend to present to their OBGYN first to get evaluated. As compared to men usually present late, and the reason for that is in men, if they usually would have a low libido. Okay, but as you would realize later, men usually would not report a low libido or blame other reasons, stress, work-related events, etc., for a low libido, and will seldom go into a physician. So the men are more likely to present with a macroadenoma. And then unfortunately for postmenopausal women, they are pretty much the same risk as well because they are no longer menstruating. So unless they have overt galactorrhea, and postmenopausal women also tend to present late, and they are more likely to have macroadenomas, just like men. So the clinical presentation would be amenorrhea or galactorrhea, and the estrogen deficiency in women also results in vaginal dryness, hot flashes. In men, there is a decreased libido and erectile dysfunction, and as a result of low FSH, they will develop testicular atrophy as well, and low testosterone results in a decreased muscle mass. And rarely will a man present with overt galactorrhea. Very, very unlikely, because as mentioned earlier, the effects of progesterone and HPL are required, and of course estrogen in ample amounts are required for ductal differentiation in the breast. And since men do not have a preponderance of these hormones, they are unable to prime their breast tissue for the milk lets down effect typically induced by prolactin. So other symptoms could be headaches, especially for pituitary macroadenomas. So for the larger tumors, they're more likely to present with headaches, not with microadenomas. Okay, so bitemporal hemianopsia is a visual field defect that typically occurs when there's an impingement of the optic chiasm by an expanding pituitary adenoma, typically a macroadenoma that extends into the suprasellar space. And cranial nerve palsies can also occur depending on especially these tumors, macroadenomas, can extend into the cavernous sinus, and hypopituitarism, merely from sheer mass effect due to an expanding pituitary adenoma, can also press on vital unaffected pituitary cells and then also result in hypopituitarism. So can we correlate prolactin level with tumor size? Yes, in some ways we can. So for example, large tumors can secrete modest amounts of prolactin, less than 200 nanogram per deciliter, and then also small tumors can secrete very high levels. So this can sometimes make it difficult to tell. However, for all intents and purposes, usually microadenomas tend to release prolactin less than 200 nanogram per ml, and then very large tumors greater than 2 centimeters can have in excess of 1,000 nanogram per ml of prolactin being released. So as I mentioned earlier about small and large tumors, so if it's a large tumor producing very low prolactin, of course this is an exception to the rule. It may be due to the fact that the involved lactotrophs are very inefficient in secretory capacity, whilst for very small tumors with very high prolactin, it means that these pituitary lactotrophs have a very high secretory capacity, or they are very efficient in releasing excessive levels of prolactin. So we have covered the clinical effects previously, but I wanted to highlight the bone effects. Remember that estrogen is required for regulation of osteoclasts in the bone. So in hypoestrogenic states, you have less regulation of osteoclasts. The osteoclasts go into a state of hyperdrive, and this results in increased bone resorption. And that is the reason why patients with prolactinomas can develop increased bone resorption. And indeed, this phenomenon may also explain pregnancy-induced osteopenia as well. Induced osteopenia. Because in pregnant women, they have very high levels of prolactin in the anticipation of breastfeeding. And for this reason, this could also impact bone health negatively. So what are the treatment considerations? So treatment is indicated if there's significant hyperprolactinemia, example, amenorrhea in a woman in her reproductive years, for example, or very low libido in a man, which affects sexual function. Okay, and this typically occurs in the setting of microadenomas. Okay, for macroadenomas, due to a risk of mass effect, remembering that the optic chiasm sits pretty much in the suprasellar region above the hypophysis. If there is expansion of a pituitary adenoma, it may impinge on the optic chiasm and lead to bitemporal hemianopsia. Okay, and also if there is extension into the cavernous sinus, remember the cavernous sinus lies on either side of the pituitary of the hypophysis, I should say, and you could actually have a tumor extending into the cavernous sinus, potentially impinging on carotid vessels and also the cranial nerves. So in which patients is observation reasonable? So in asymptomatic patients with microadenomas, especially if they are not having any dysregulation of cycles or no bothersome breast symptoms, you may observe. So this is more likely in postmenopausal women because they are not achieving any fertility at this point, and they are less likely to have galactorrhea as well. So what are the therapeutic considerations for prolactinomas? Typically cabergoline or bromocriptine. These are dopaminergic agonists, and how they work is, remember the initial pathway that we reviewed, they will decrease prolactin secretion and normalize serum levels of prolactin, and consequently they have a form of tumoricidal effect, or they will lead to a regression of the prolactin tumor. Monitoring involves checking prolactin levels every 2 weeks initially until improvement or normalization of serum prolactin, and then we titrate the dose until prolactin normalizes and repeat MRI in about 3 to 6 months to ensure that the tumor has shrunk. So cabergoline is a longer acting version of a dopaminergic agonist, and it has lower GI side effects. It does cause nausea, dizziness, and sometimes headaches, and there is a warning about compulsive gambling with this agent. Okay, so it can cause a few neuropsychiatric symptoms. So it's important to notify patients about the possibility of compulsive gambling. Bromocriptine, on the other hand, has a more extensive record because it's been on the market much longer. It also causes similar side effects such as nausea, dizziness, postural dizziness, obviously, and headaches. But it also does cause GI upset as a potential side effect. So the long-term follow-up for these patients, we always want to use the lowest dose possible in maintaining normal prolactin levels. We could always attempt a possible 2-month holiday every 2 years to see if tumor regrowth recurs. So for macroadenomas with sphenoid sinus extension, then we need to always watch for CSF rhinorrhea as the tumor shrinks and involve neurosurgery if needed. And we kind of spoke about that cork effect that happens when you have a large prolactinoma sitting at that critical position between the suprasellar region and the cella, such that if the tumor shrinks away, you could have leakage of CSF into the cellar space, leading to CSF rhinorrhea. So there are options for other alternative treatments as well, such as transsphenoidal surgery or gamma knife radiation, especially for patients with resistant or intolerant, or patients who are intolerant to medications, especially cabergoline or bromocriptine. This is, however, quite rare that this happens. So there are some special scenarios that we have to consider. We did mention the intolerance to dopaminergic agonists or even resistance, where we may have to look at alternative treatments. So I reserve this last scenario for the end because it's very important, understanding how to manage prolactinomas in pregnancy. Remember that in normal physiology, there's global hyperplasia of the hypophysis, and pituitaries can actually reach up to 1.2 centimeters in size postpartum, and this occurs because of a placental estrogen surge, which increases lactotroph size and prolactin secretion. So prolactinomas, typically the microadenomas less than 10 millimeters, can be observed, whilst the macroadenomas may be a little bit more challenging to manage in the setting of pregnancy. So let's quickly review that. For microadenomas, they are generally benign, minimal risk of symptomatic enlargement. A small percentage may develop headaches or visual changes if there's an appreciable increase in size, although this is quite rare, so less than 5% will develop obvious mass effects. Usually, the management strategy would be to stop dopaminergic agonists, so you stop the cabergoline or bromocriptine once the patient is pregnant, and then you monitor every 2 to 3 months, typically every trimester, and do a clinical evaluation, asking for symptoms of compression, headaches, and visual changes, and sending the patient to an ophthalmologist for visual field assessment. And then the plan will always be to restart dopaminergic agonists if there is a significant growth or change in symptoms. And postpartum, it really depends on what is being done for the patient. Since most patients have microadenomas, these are unlikely to expand. So if the patient is not breastfeeding, then we can always restart dopaminergic agonists. But if the patient is breastfeeding, then we can, and the tumor is stable in size, we can kind of hold off on restarting treatment. How about macroadenomas? So for macroadenomas, remember they are greater than 1 centimeter in size, and these are at a higher risk for enlarging rapidly during pregnancy. They can increase up to a third, about up to 36% of patients can have mass effects, symptoms of mass effects such as headaches and visual field loss. The plan will always be to shrink the tumor with a dopaminergic agonist and typically bromocriptine, or if the patient is resistant to dopaminergic agonists, then our hands are tied and we have to do surgery. If the tumor is not near the chiasm or shrunk, then we could always stop the dopaminergic agonist and continue to monitor. But if the tumor is large and near the chiasm, then the recommendation is to continue dopaminergic agonist throughout the therapy and throughout pregnancy, and with close follow-up of visual symptoms and headaches every 3 months, and low threshold for ordering an MRI of the pituitary gland if the patient is to present with headaches or visual field defects. If the tumor is rapidly growing, then aggressive high-dose dopaminergic agonist therapy, surgery, usually would be reserved if the patient is resistant to dopaminergic agonists, or if there's life-threatening and vision-threatening changes happening with the patient. So post-delivery, let's quickly review that. As I said, breastfeeding is permissible if the tumor is small. That's typically a microadenoma, less than 1 centimeter. Then you can always restart dopaminergic agonist. For persistent hyperprolactinemia, if the patient is not breastfeeding. But if they are breastfeeding, you can hold off on doing that. So these are the key takeaways. I'll leave this on the screen. And thank you so much for joining me today. I'm looking forward to seeing you on future presentations.